Welcome to the ABQ Accent, where catalysts, innovators, and risk takers share what their accent is on their work. Like a spoken accent, we all have an inflection or emphasis on where we put our energy. Join us to learn how these folks are putting their accents to work, building their vision of the future, and how you can get involved. Hi, this is Mariah Harrison, and we are with the ABQ Accent today. Thank you all for joining us, and also thank you so much, Liam, for being with me today.
Thank you so much for inviting me. I'm super glad to be here.
Yeah, my pleasure. Lots to talk about today. So I'm going to give you a little bit of an intro, and then I want to give you the time to talk more about your background and walk me through some of what brought you to where you are today.
Okay.
Yeah?
Sounds good.
Okay, you know how this goes. So bear with me because there is so much to celebrate about your work and where your work is going. Oh, I'm so excited. Focus. Liam Westgate is a licensed clinical social worker and is a social work advocate with extensive professional experience in social work policy, practice, research, and education. Truly, it's the gambit of the work. He is board certified clinical supervisor, has held numerous organizational leadership roles, serves as an educational consultant, a medical social worker, and currently serves as the director of community and clinical linkages at Presbyterian Health Services. Congratulations.
Thank you.
Love that. Today we're going to talk about how all of that comes together. So much of these things are, you put energy into identifying gaps, looking at systems, looking at how people-centered interventions can make up some of this beautiful work in healthcare. And a little bit more to go about your work. Mr. Westgate continues to serve as a faculty member and instructor at the University of Maryland while working and living in Albuquerque, New Mexico. His scholarship includes numerous things like integrated behavioral health, working with individuals with chronic and life-threatening illness, healthcare and social policy, and health equity, as I said, the gambit. He's received recognitions and awards, including National Academies of Practice as a Social Work Fellow, the Alumni of the Year Award, Energizer Faculty of the Year, Energizer Faculty Award for 2023. Innovation in Social Work Award, Exemplary Faculty Member of the Year, and the Dean's Teaching Award for several consecutive semesters, and most of these are related to, again, the University of Maryland. Mm-hmm. He's been published numerous times, including the Journal of Sociology and Social Welfare, and I would recommend that folks reach out and maybe do a Google search for some of this academic work and research because it will impact your life. It will impact your loved ones' lives. And I want to hear more about this broad scope. So tell me more from your perspective.
You know, it's really interesting to hear about your work from someone else and to hear other folks reflect upon that. Because when you're in the moment, all you see is what's in front of you. Mm-hmm. All you see is the person or the family in front of you. And I think I had a very meandering path to becoming a social worker. I never set my mind and said, that's what I want to do. Yeah. I think if you ask my mom, she would say, I always knew you were going to be a social worker since the age of 6. I know. Because you always seem to have that disposition of wanting to help people or having a sensitivity to someone who was affected by something. Mm-hmm. I think that's something I just always had. And the idea of having a framework for there's a profession or there's a job or there's a thing that you can do with most of your time that syncs with the way that you are as a person, that was kind of a surprise. So I had kind of a meandering path to being a social worker. And I think all I really knew when I was kind of on the cusp of applying for my master's degree, which also seemed like another world, right? To not just go to college, but then to get professional education beyond that.
Something specific, yeah.
Yeah. But the two things that I think that I knew that I wanted to do is I knew that I wanted to help people and to be in some kind of position to facilitate access to the things that people need. Right. So I found my way to being a social worker, and you're seeing a lot of the downstream outcomes from that path. But as a social worker, my first job when I graduated with my MSW, I actually worked in Washington, D.C., which growing up in Baltimore City, it's geographically close. It's another universe to work in some of these different spaces. But in that first professional role, I worked as what's called an employee assistance specialist, and that's really just a social worker for the workplace. And being in that world kind of opened up this whole array of opportunity that, there may not be a certain kind of an organization that you want to work on or a certain kind of problem, but there are people in all of these different complex systems that are also experiencing real life, right? So you could be somebody that's like on your personal trajectory to work, in an office or a government job, or to be a firefighter or a first responder.
Yeah.
And then something happens to you. Maybe a loved one gets sick. Maybe you struggle with a substance use concern, or maybe you struggle with a mental health concern, or something like that touches your life that has some semblance of stigma, which can beget shame and can really close a person's orientation down toward accessing help, right? So as an EAP, I had suddenly this firsthand exposure to all of these different people and all of these different systems. And, when you're reading my bio and you become aware I have student loans, right?
Yeah. Yep. I didn't mention the MSW and the MBA.
All the things, right? But when you're in some of these different positions, you also learn that there's different ways that you can intervene and help someone. You could be sort of on that preventative perspective, right, of early identification of issues that are going to have this whole cascade effect in a person's life, or maybe you're meeting somebody when they're in some crisis.
Yeah.
But wherever you meet them, I think the through line through that work was that there's always something you can do, right? Wherever you meet them, wherever you meet your clients, there's always something that you can do. And I know when we talked ahead of today, I was also reflecting on things that other people taught me as I've been doing this work. And in social work, we always say meet the person where they are. But I've had the privilege to meet other folks along my career that added a second piece to that statement, which is meet people where they are, but don't leave them there, right? So I worked in that field for 5 years. I did a lot of things. I had a lot of experiences that you wouldn't think were going to be typical experiences in the early part of your career, right? And one of the experiences that I had was working also as somebody who did crisis management, or provided support to people who maybe had been impacted by workplace violence, workplace, critical events. And, I had the privilege to be part of, people's really precarious moments. But the other lesson learned in doing crisis management work is that you may not always be there for someone's whole life, but you're going to meet them in a critical moment, and can you do something that can contribute to opening a door to healing, right? But when you're a consultant...
It's a beautiful perspective.
Yeah. Because you don't own somebody's success, and you also don't own somebody's precarity, right? That's kind of the humility piece. But after doing that work for about 5 years, and when you're working in a small place... there's the allure of being part of bigger systems, and what could be more of a bigger system than healthcare. So I went from a team of less than 20 to, an organization. Initially, this is my work in Baltimore, and I was there for well over a decade, to a very large healthcare system, very community-centric, very similar in a lot of ways, as I'm sure we'll talk about with Presbyterian, that community orientation. And then I just took a hard right into a totally different field and a lot of different learning as a medical social worker, which in hindsight, super ironic, because when I went to be a social worker, to my MSW program, I said, I don't want to work with families and I don't want to work in health.
What?
And I know. And then I was like, wow, I really like working with families and I really like working in health. And it's actually, you just never know, right? But you have to be open to where you're being called to be useful, right? And I'm sure as we kind of connect these different dots, that's always my barometer of, do I belong in a place? Can I be useful? Can I have an impact, right? And then that kind of tells me and kind of helps me calibrate about where I'm going to go next. But I loved that next job, and I got to work. You heard a lot in my bio about working with folks with chronic illness and life-threatening illness. And I spent about almost 10 years working with people who had cancer diagnoses, end-of-life diagnoses, or terminal diagnoses, working with families in various forms of crises. And it's funny when you do that work and you go outside of the hospital and maybe you go to like a social event and people say, what do you do? And if you want to depress them really fast, you tell them this is the thing. And they would say, how do you do that? That seems so heavy. Like, how can you hold all that in your heart and everything? And I'd always tell them the same thing. When you work with people with really intense health issues, it's actually really life-affirming because now you have the privilege to meet folks that are doing everything they can to be in this world. Yep. Everything they can to be with family, to show up for their kids, for their parents. You see families that mobilize in ways that they typically wouldn't. And that was really inspiring, right? And doing that like changes everything. And I'm sure we can like take a pause point there to think about that. But when I think about what good work is for me, it's, can I be useful? Can I create a safe space for someone to have the experience that they need to have? And can we create a situation together where people can have an opportunity toward healing or closure or whatever that is? But my patients are kind of like the people I carry with me, like in my head, because they teach you lessons too, right? They teach you lessons too.
You're open to that though. You know, you put yourself in a place where you're being of use so that you can take in information and improve their situation and the situation at large. And you know, I think that's an intentional perspective that I think impacts your work every day.
Most definitely. You know, I think, as I'm sure we might have the opportunity to explore, like when patients come into care systems, there's a lot of demands that are put on them, right? To tell their history, to tell their like most private moments that they may not even have told their loved ones. But there's a lot of demands and duress that are on them, right? And many patients know that in order for care to work for them, they have to be as transparent as possible, right? And labor through those kinds of things. And I think in seeing that enough, it makes you also be like, if we are asking you to do that, if we are asking you to be open, to be vulnerable, then it's also on me to also meet you in that space so that I'm not one of those people that's sort of contributing to this system being even more opaque or even more anxiety inducing. But it kind of, that openness teaches you how important it is to be compassionate and to be gentle, and to also have humility that what is not new for you is completely new for that person, right? So you know, in the ICU, for instance, you know, I may have seen, you know, 10 or 20 different similar scenarios in the same day, but in each room, that's a private universe. Right? That's a private universe.
Behind the curtain, behind the door.
Yeah. Definitely.
The compassion is a critical through line in your work, and I've heard it both ways. You can't teach compassion, but at the same time, I believe that you can teach components of care-based systems and communication that sort of support those structures of compassion. And so as you're talking about being open to these people's stories and the details of their lives, I'll supplement that by a quote that I found from you that I really love, and I've heard it in different ways, that we are the keeper of each other's stories. And storytelling is incredibly powerful, not for just, you know, historical, cultural keeping, but internal family knowledge, and again, through this healthcare system. And so your perspective, I'm just going to add to what you said with your own words, because I think it's really beautiful. As a social worker, I have the esteemed privilege of bearing witness to the resiliencies, tender moments, crucibles, and lived experiences of those that entrust me with their stories. This calling is to serve is a beautiful struggle that never ceases to reveal the transformative power of connection and community. I believe that in our brief time here on earth that we have the opportunity to leave behind a beautiful legacy of freedom and joy. It is this deep belief that inspires my work in supporting our helpers, advocates, and healers. It is my hope that you will join me in this belief and this call to action. We are, after all, and ultimately, here for the sake of one another. Okay. It's along the lines of that quote that we're all just walking each other home.
Mm-hmm.
And so what you're doing is you're taking the idea of connection to a really incredible level of usefulness that bears usefulness in our personal relationships, our healthcare systems, and so forth. And so when you say that part about it inspires your work to support our helpers, our advocates, and our healers, that's kind of where we also see the tangible pieces of your work at Linkages and in your scholarship work.
Yeah.
So let's talk a little bit more, if you will. Describe what your role is in Linkages and what that program does.
Sure. So, wow, it's like very surreal to also think about this. As of May of last year, I, uprooted my life and came to New Mexico, and that I'm very happy about. And living in New Mexico was my ultimate bucket list. Like this is where I want to be.
It's drawn you for some time.
Oh yeah, 20 years. So I found my way to Presbyterian and have the privilege right now of working in the community health department, which is really just an amazing array of programs that when I think about what community health is and how that filters into community and clinical linkages, which is the division I'm in, the community health program is sort of the intermediary, right? If you had to think about the hospital, like the traditional hospital system, which is the four walls and what happens within acute care centers. And then we have doctors' offices and all these sorts of bricks and mortar programs. And then we have virtual care and all of these kinds of things. But at some point, you need to have a mechanism within healthcare that is really making that connection, there's that theme again, between what the community has identified as particular and key areas of priorities and how can the system respond to that. Right. And it's interesting work because in all of the other formal systems that I mentioned a moment ago, there's structures and there's, tradition, but the idea that healthcare can exist in this permeable space between these formal systems and the community, that's a really powerful concept. Community and clinical linkages, the team that I'm on, and again, have the opportunity to serve as a director, oversees, I would say, three key areas. One is the work of our community health workers. And I think it's important to also preface that my role is really centered on the central delivery system. So more Albuquerque proper, Bernalillo County, right, all of those kinds of things. And then we have a whole arm of work that's done by our regional team in the Santa Fe area. So I have a counterpart in that area that's also doing awesome work. But we also have to tailor this differently to the needs of each program and community. But we have community health workers that currently are positioned primarily within primary care settings. And we can probably wax poetic for 8 years about why that's significant. And then we also have a peer support worker program or peer support specialist program. And that team is predominantly focused in our emergency departments. And so we can talk about the initiatives that are happening there, but really they're there for early engagement with folks that might have substance use concerns or relevant behavioral health concerns. And they're, again, really awesome in their role of providing that proactive, compassionate approach. The third body of work, just because that's not exhaustive enough, is, and this is something that sort of lives on my team, but also across Presbyterian, is we have a pretty massive health effort across our enterprise to do health-related social needs screenings. And so that means that if you come into, let's say, your primary care office or different parts of our system, we're asking relevant questions about what are the non-medical factors that might be impacting your health, right? So those are the three bodies of work. And then, of course, from there, there's varying special projects and initiatives. And I also want to caveat that some of the CHW program and the peer program is also interfacing with our OBGYN clinics as well. So again, that's a huge area when we talk about community health. But all that to say that one of the things that's made all of that work a little easier is that we have a phenomenal team of people that are they're invested and they're there, right? I'm very, very inspired to see the level to which like the CHWs and the peers have integrated within the system and really been identified as not just valuable team members, but subject matter experts, which is, a big testament to their contributions. But yeah, and through that also, like we support other initiatives on our team that might happen within community health or things that are adjacent to our initiatives.
So real quickly, how would somebody sort of take me through what an experience might be if somebody came into the emergency room and they had been in a car accident? Which one of those groups would interface with them along with the healthcare, the nurses and whatnot?
I think specifically, maybe less if there was like a medical event, but let's say, for instance, a patient comes into the emergency department and they have a substance use concern or risk of overdose or something in the world of polysubstance abuse and that sort of thing. We have formalized screening processes that we do, that our staff does. We also have peers that kind of, monitor, right, from their own vantage point, folks that may be coming into the emergency department. And once, let's say, a patient is identified and in need of services, that outreach could happen face-to-face if the peer is positioned there in the hospital. But we also have, obviously, a lot of hospitals in New Mexico that are in, more rural or remote areas. So to address those patients' needs, we've set up virtual peer support. So we can dial in via an iPad and, coordinate with nursing staff and or provide that consultative support. But once a peer links up with a patient, they are really at that point, not forcing an intervention, obviously. It's a very patient-centered process. So they're assessing, where is this individual maybe on their change trajectory and their readiness for services. But if I had to say what's the universal intervention, our peers always identify something they can do. So maybe it's linkage to a recovery program. If that person's ready in the moment and there's capacity to do that, maybe it's education. Maybe it's sitting literally, as I've watched some of our peers do, sitting at the bedside and just say, hey, I've been there. And, I just want you to know maybe there's like a different way that we can approach this challenge together. And we have such a broad array of skill sets and lived experiences, right? But that's the other like through line for peers and particularly in peers, a little bit differently in CHWs, that there's a shared lived experience. So that person who is often maybe experiencing one of the most stigmatizing concerns you can have is meeting somebody who's going to be able to, mitigate that and remove that, right? And kind of, meet somebody at eye level versus some of those power differentials that can sometimes be a barrier. But I also want to, acknowledge that the peer work to be successful is not done in isolation. They've done an amazing job building relationships with our providers, and we have very, very invested, addiction medicine providers. So start, again, connecting those dots between the different points of light, right, of folks that want to be able to find a way to make this work, and making those connections across teams is really what makes that powerful.
Well, and I think I love that what you're saying about it being essentially a group effort, namely participants who have had the lived experience that are walking into a room to support somebody, like you said, where they are, to help guide them a little further on their path of growth and evolution and healing, whatever that looks like for them. And it's something that I think is at least what I've recognized over the last couple of years, that it's a growing movement of peer support workers.
Most definitely.
Tangentially in tandem with community health workers, and more people understanding that they have a role to play as a recovering addict or as whatever their history is, that they have a role to play in other people's recovery.
And that's I think that's a really important thing to understand when you're, supporting teams, building teams, right? Is that for some of us, right, part of our own healing is giving that back. So with that, when you were saying earlier about like, how do you teach compassion, right? How do you teach those communication skills? I don't have a perfect answer for that, but you kind of learn things along the way that you're like, these are some useful things, like our strengths and vulnerabilities are identical. So if you're a compassionate person, you're going to give a lot, right? That becomes your vulnerability, right? So a lot of this, and your strength and vulnerabilities at the same time. So a lot of this is also this balancing act too, right? Of making sure that as we build teams to care for community, that we're also building systems to care for teams.
Yes. Yes, we want to say more about that. Yes. Okay. And towards that end, I think some of what we can talk about here is, you mentioned last time how, let's see if I can get this right. There needs to be support for mechanisms of deliberation. And this is where you were talking about bringing into conversation the fact that these groups of people are trying to normalize uncertainty, and that it's okay to ask one another questions, because in the healthcare field, typically, you don't want to be seen as weak or not knowing everything or not having the answers right there. But if you're working with a team who's willing to have the conversation about the best practices and the best next thing for this particular patient where they are, right? Like that's something that you can teach a team to work through and work with. Say it better than me.
I think you had a pretty good summary. I think I would add maybe a few things to that, which is, for the entire time that I've been in the world of healthcare, there's been this larger discourse of this pendulum swing, right? From sort of traditional medical model, sometimes paternalistic approaches to care, to what does it mean to get to the place of patient-centered care? Right. And sometimes that's easier said than done, right? You have a complex system, you have diversity of skill sets, you have different kinds of expertise and all of these kinds of things. And we don't have patients that we're serving that have like one problem. Right. There's complexity and there's like a differential approach that you need to have for other folks. And
you're seeing them at one point in time.
Exactly. And you're seeing a very incomplete picture of a person's life, because when somebody comes to the hospital, it's not their best day. Right. So you're not seeing them at home with their family. You're not seeing them when they're in their optimal space and point of resiliency, right? Sometimes you're just seeing them in their most vulnerable moments. So there's a lot of things that are situationally just really challenging with figuring that out, right? And kind of squaring that circle. I spent a lot of my, I hesitate to say academic career. There's a term, it's called pracademic, which is sort of the practice-based academic. But I spent a lot of my pracademic career talking about things like interprofessional care and how do you teach that, and how do you move away from power dynamics and flatten the relationships between providers. So all that to say, like, having that deliberation, having those mechanisms to ask questions, but also having the ability to ask questions like, what's in the best interest of this person, right? Based on what they're sharing, based on what we're seeing, right? How do we prioritize? And then how do we make sure that we're keeping the patient at the center so that they can self-identify, right? This is at the top of my list.
Because they are the experts in their life experience.
There's the thing, right? It's a huge lesson in healthcare to move to this orientation that the person that I'm meeting, they're the expert. And that my role, that's the humility factor, becomes how do I facilitate, right? How do I keep things moving so that I don't enter into some of these more complex impasses with folks. But one thing we talk a lot about, not just in social work, but in interprofessional care, but even in the world of how do we prevent ourselves from burnout, right? Is how do we maintain curiosity?
Oh, yeah.
Right? Yeah.
Gosh, I think the curiosity comes into play probably more than we think about it. It's like it's always sort of there, especially for a pracademic.
Yeah.
And in the short time that we have left, I want to say so many things. I want you to say so many things, but I also want to bring it back to, there are ways that our community can be better informed about how they can be their own advocates and work with medical workers that are advocate-based. But your work, I think, centers around a lot of trauma-informed care and educating healthcare workers about working with folks from that perspective. And also we were talking about ethics in this space and how it's often, you said, I think earlier, about how there's a gap between those educational perspectives. say that better than me, because I want to highlight really that this is one of your deepest passions about work.
Yeah. So, and one of the things that you mentioned was some work that I did on a national trauma task force. And I'm going to spare you the multi-week, multi-month effort, but the center of that was really looking for literature that made the connection between ethics and trauma. And there was really not a lot.
When you say it out loud, it sounds wild.
It's wild, right? There's a lot of stuff on ethics. There's a lot of stuff on trauma, but how do you make a bridge between those two things, right? How do you take the really valuable lessons of ethics and, link that together with trauma-informed care? And when we talk about trauma-informed care, I think of both of those things as like lenses, right?
Yeah.
Ways of seeing the world. And when I think about the connection, especially between things like ethics and trauma-informed care, maybe one of the most commonly known ethical principles that folks are probably familiar with is do no harm, right? But the other really important part of ethics is also do good.
What?
Right? Right. It's called beneficence, right? That whatever you should do should be oriented to doing good, right? And sometimes when we have these incomplete discourses and discussions about ethics, we hear what you shouldn't do rather than what you should do. Trauma-informed care is also a lot about that too, but it's also about taking some of those ethical frameworks about doing no harm and making sure that we're promoting good. And also thinking about the connections between systems again, right? So a lot of times when people hear about trauma-informed care, we think about that as it pertains to our patients, but it also pertains to how we lead, how we build teams, how we have optimism. Right?
Yeah.
One of the challenges, I know this firsthand from working, whether it's in an oncology unit or an ICU, is sometimes you don't always get the benefit of seeing a good outcome, right? Because you see somebody in these really, really critical moments. But it's really important then to preserve that imagination that even beyond the reach of my work with somebody, that good can happen, right? That I can have optimism and hope. So, but when I think in a very, very brief version of making those connections, it's not only how do I not add burden, but how do I promote good in this person's life? And how am I also building different mechanisms to have optimism, right? Hope and optimism about the folks that I work with and the folks that I serve.
That's something I remember we were talking about specifically is an overarching piece of your work is that you're trying to make these things accessible and bring in the hope.
Yeah.
There's always room for hope.
Yeah.
In whatever you're learning or practicing. And it's also an intentional perspective.
Most definitely. Most definitely. I read a lot of, in my non-free time, a lot of books. I find myself reading a lot about of the works from Rebecca Solnit. If you've read the book Hope in the Dark or Orwell's Roses and all of these kinds of things. And she really eloquently has an approach to writing about kind of meandering through what we would think of as disconnected things.
Yeah.
But one of the things that I loved about Hope in the Dark, which I want to give a shout out to my best friend for suggesting I read that, right? But the whole premise of that book is that hope's not a thought, it's an action, right? It's not a passive approach to life, but it's what exists in a world of possibilities, right? And even in a place of uncertainty or precarity, hope exists because there's the possibility that a good outcome could be amongst many of the different outcomes.
Yeah. I think you read somewhere also where people were in dire situations, those who had hope tended to live longer and or had better health outcomes. I think it's an integral piece of your mindset.
Yeah.
It can be.
Yeah. I've met a lot of patients that have been in some of the most complex situations, and you're just how is this working, right? How is this possible? In an oncology work, one of the things we talked about a lot is the sacredness of hope, right? And that when you're providing care to someone, and I think that translates to the work of the CHWs and the peers and all the folks that I get to partner with and work with now. But when you're taking care of folks, you have to take care of their hope, right? Because that belongs to them, right? And so nurturing that is so important when you're negotiating all of these different challenges.
I just want to hold that for a minute. When you're taking care of somebody, you need to take care of their hope. I think that's a really positive note that we can end on today.
Perfect.
With the knowledge that there will be more to come from you, because I think you're a very deep well of knowledge and compassion that I'd like to share with more people.
I really appreciate this conversation today, and I appreciate you in the world and asking those questions, and also just the chance to not just speak about the stuff that I do, but really to elevate the people around me, especially in this moment, that also give me hope and also give me inspiration. And I think the last thing that I would say is that, you know, a lot of healthcare and social work is actually pretty irrational when you think about it.
Irrational?
Mm-hmm. Because it's a whole body of work that's predicated on taking care of strangers, right? Everybody that gets up, goes to the hospital, goes to a clinic, or does work as a social worker, you don't know those folks,
right?
But you feel beholden to them because you feel that this is part of my human family, right? And I think that's the other thing. When I started to feel awareness of this language of hope, I'm like, that's what I've been observing.
Mm-hmm. And maybe that's what you've been feeling in yourself. And that's what there's so many other things I want to say. But as you mentioned, the other people that are around you that you want to lift up, you're grateful to your mentors and to the people in your life that saw you when you needed to be seen so that you could be supported in your next chapter, whatever that looked like. And I say thank you to them too.
Definitely.
Yeah.
Definitely.
So you did say that was, good enough to leave on. I'm just making sure I don't have any other questions that are lingering. And of course, there are lingering. And that's kind of the point of these conversations, is that there is so much for people to engage in different ways, whether it's reading a book that you recommend or maybe looking up the website for the Linkages program and seeing if there's ways that they can integrate their own expertise. Anything else that maybe people could reach out or look for?
I would just acknowledge a lot of the work that's being done by our Community Resource Center and the Food Pharmacy Initiative.
Yes.
And I mean, there's a lot, right? There's a lot of really powerful work that's being done to close those gaps, right? So that people feel safe, so that they have their needs addressed. But I feel like there's such an exhaustive list. But I think I would definitely invite folks to become familiar with Presbyterian's community health initiatives. You can learn more about that.
Yep.
Absolutely. And I would also just want to acknowledge, my colleagues and Lee Caswell. I do want to acknowledge her, who's our vice president and has been so instrumental in, creating mechanisms for the right people to connect to build these systems. So we have a lot of really great leaders and really great colleagues.
Yeah. Thoughtful of you. Thank you for your gratitude. And thank you, Liam, for your work today and every day that you show up for other people. It makes a big difference. Appreciate you.
Appreciate you back.
Yeah.
I hope we get to do this again.
Yeah, why not?
All right. That sounds good.
We'll have a different centerpiece next time.
Okay. We can steal a different plant.
Yeah.
Sounds good.
All right. Well, thank you, everybody, for joining us today, and we hope that you come back for another ABQ Accent.